Well, thank you very much for giving me the opportunity to speak to you today. My name's Ben Mullish. I'm one of the clinical lecturers at Imperial College, and this is just an update on where we've come from, where things are going, and some thoughts about the future for fecal microbiota transplantation. Here are my disclosures. And it was really two different factors that have kind of brought fecal microbiota transplant to the fore. The first was, of course, the explosion of interest in next generation sequencing, microbial sequencing techniques that have happened over the past 10 or 15 years or so. And coupled with this was a growing molecular understanding of Clostridioides difficile infection, previously known as Clostridium difficile, C. diff, etc. And what's been very well established about C. difficile infection for quite some time is some basic elements of some basic, pretty unique elements of the etiology and pathogenesis. And we know it's very well associated. The major risk factor for it is recent use of broad spectrum antibiotics. So in other words, if we look at this figure over on the top left, we know that the typical risk factor is an older or frail person who has been given exposure to broad spectrum antibiotics and has disruption of the gut microbiota, particularly the huge trillions of bacteria in the gut that are being killed off as collateral damage as antibiotics have been given primarily to treat, say, a urinary tract infection or pneumonia. And that increases the risk of C. difficile spores germinating, growing, and then releasing toxins and causing problems in the GI tract. And if that risk is removed, if antibiotics are stopped, that risk therefore reverses. And C. difficile would become harder to treat about 10 or 15 years ago when all this was coming to the fore, particularly due to the arrival of hypervirulent strains of the disease that were less responsive to typical first-line agents such as metronidazole. And then the idea arose that therefore, if disruption of the gut microbiota is part of the pathogenesis of C. diff, can we actually treat the condition by restoring a normal gut microbiota? And therefore, could we take a healthy person who hasn't been exposed to antibiotics, is otherwise generally healthy, take their stool samples, remove all the waste material, keep the healthy gut microbiota, and restore that to someone with C. diff? And while this strategy had been around in sort of smaller forms for almost 50 years, and historically described even in ancient literature in a much smaller scale, this first came to Western medical prominence back in 2013 with the first randomized trial from Van Noot et al., published in the New England Journal. And this was a trial where people with recurrent C. difficile infection were randomized to receive either fecal transplant via a nasoduodenal tube. The donors were a hodgepodge of people who worked in the hospitals, volunteers, etc., or randomized to receive vancomycin alone, the typical standard of care therapy, or vancomycin with some bowel lavage. And the trial was stopped prematurely by an ethics committee because the people with fecal transplant were doing so much better than those just given vancomycin, with 81.3% cured in remission after a first FMT, and 93.8%, so that's 15 out of 16 in remission after by the time of second FMT. And at the first time, about this time, there started to be some appearance of gut microbiome literature that showed that the gut microbiome composition was hugely disrupted in people with C. difficile infection, was restored rapidly and sustainably back to a gut microbiome composition similar, comparable to that with healthy donors within a very short time after just a single FMT. And from that point forward, there was a huge interest in other FMT for C. difficile studies using a variety of preparations, a variety of routes, a variety of comparison arms. And the conclusion is almost whoever you pick as your donor, however you prep your FMT, however you deliver it, whatever's your comparison arm, is that FMT is a very highly effective treatment. And this is a recent systematic review and meta-analysis we've involved in, and where lots of these early classic randomized studies are looked at by meta-analysis. It can be seen that overall there's a pretty strong signal favoring FMT. And in light of the excitement about this, and the refinements that have occurred in modalities of administration, we were involved in writing some national guidelines for the British Society of Gastroenterology and the Healthcare Infection Society a few years ago. And there have also been some earlier NICE guidelines and some updated NICE guidelines as well. And this has been coupled with recommendations from European bodies, American bodies, and other international societies that have all given some insight into best practice for the use of FMT in the setting of recurrent C. difficile infection. Just to give an insight for how widespread this is in Europe, at least, here is some recent data under review for how many FMTs are being done as of 2019 in Europe. And as you can see, Britain is holding its own in terms of the a number of FMTs it's doing, but there's pretty widespread use throughout at least most of Western Europe, and increasingly throughout Eastern Europe as well. And that sort of pattern has been coupled worldwide, that while Western countries with a strong academic basis who've got an interest in the microbiome and microbial sequencing have been the first to take this up, we start to see some rollout to other centres as this has become more established. So who, when we're looking at C. difficile, do we book as recipients? These are typically patients who are on their third episode of C. difficile infection or refractory disease, in other words, and just not responding to typical antibiotics. And often patients have had prior extensive antimicrobial standard of care therapy, including the vancomycin taper or fidaxomicin or bezilotoxumab. In terms of contraindications, there were lots of concern about these at first, but really anaphylaxis is the major one that still is outstanding. Although some centres would say picking a patient-selected donor who has been on an exclusion diet may be sensible. It also makes sense that if, for instance, a recipient had celiac disease, that we try and identify a donor on a gluten-free diet, of course. Where there are cautions or where there's concerns or where things need to be considered on a case-by-case basis is particularly in the case of children with recurrent C. difficile, where there obviously needs to be much more of a discussion of risk versus benefits, particularly because of the relative novelty of FMT use in this setting and concerns about potential longer-term effects, although it has still been recommended by expert bodies. Use in pregnancy and lactation, thankfully it's a rare scenario, but there are some case reports where it has been used in this scenario and appears to be safe and effective. Immunocompromise has been a huge concern. If we are flooding a patient's gut with live bacteria and they're immunocompromised, what could be the sequelae of that? But actually in practice, there have now been a number of large case series whereby patients with a range of immunosuppression, HIV with low CD4 count, recent chemotherapy, hematological malignancy, immunosuppressive therapy have all been looked at. And FMT appears of comparable safety to the settings of people without immunocompromise. There was also concern about IBD, given this is another condition associated with perturbation of the gut microbiota and where a range of immunosuppressive therapies, not least biologics, are used. This is some recent data that we've been involved in over on the right. And in particular, this was a prospective study of 50 patients receiving FMT for C. difficile infection, which was superadded in the context of established inflammatory bowel disease. And the particular concern was about the risk of inflammatory bowel disease flare. However, while earlier retrospective data report this risk of pretty high, in practice we only found this in 1 out of the entire patient cohort included. So it appears to be much lower than was originally suspected. Where do we get hold of donors? This is obviously something that is pretty difficult. This is a underground advert from Boston, whereby public adverts are put out in the way you might see for a blood transfusion service or stem cell transplant service to try and get people to come forward. We've been involved in some other work, which is looking at donors to and what factors might be what might help or encourage or discourage people from coming forward. Well, we've taken the view in the UK, and I think others have pragmatically of only covering donor expenses and not actually paying per donation. This has been what's taken place in other settings. Who do we pick as donors? Well, here's the sort of list of current things we think about. I think there's sort of 3 things that we really need to look at for donors. We look at general factors. So because the microbiota changes with age, we've tended to pick people who are healthy between 18 and 60. We want people with a healthy BMI, so ideally no more than 30. And we also exclude people who are on previous antibiotics. So some settings this might be for 6 weeks, and other settings this has been for a longer period of time. We first of all undertake an extensive history, and we're looking at microbiome-associated diseases. This, of course, isn't just GI and liver diseases. This is a range of different diseases, including neurological, metabolic diseases, etc. And we also do some risk assessment as well for potential pathogens that may be associated with these people, for instance, risk factors for blood-borne viruses. And then we go on to do a range of laboratory tests. So just to give an insight, this is from a recent European a guideline about what we do there. We take an extensive history of infectious diseases, a travel history relevant to areas that might be endemic diseases, diseases associated with perturbation of the gut microbiome, and risk factors for bloodborne viruses. And then here are the extensive laboratory tests, some of which have been recently updated, as we're going to talk about very shortly. Often the category is now raised of us wanting some particular additional tests if the recipient may be immunocompromised, particularly in terms of checking CMV and EBV status. Donor screening has moved on over time. There was a report in the New England Journal from 2 years ago of 2 patients contracting a multi-drug resistant ESBL E. coli from donor to recipient, hadn't been screened for in the donor. 2 patients got ESBL E. coli bacteremia, one of whom died. And so screening for multi-drug resistant organisms, at least CPE and ESBL is standard practice. And of course, COVID last year, as it did for so many aspects of medicine, totally shut us down, where we weren't sure how to go about screening donors or how we can safely administer to recipients. But fortunately, there's been some navigation through the help of international collaborative networks coming together. And this is a combination of history, nasopharyngeal swab, taking a history of vaccination status, and now increasingly that just more recently has been our ability to actually check for the presence of SARS-CoV-2 in stool, which has also helped us reestablish services. In terms of the mechanics of FMT prep, in those earlier studies, such as that Dutch paper from 2013, that it was still very much fresh stool that was used. The problem with this is, of course, if you're given a fresh donation on the day, you really can't have that certainty that there's nothing, if you've just got a donation on the morning and you want to use it in the afternoon, you don't have that certainty of what pathogens may be in that sample. And with the arrival of protocols that looked at frozen FMT, in other words, where you could add glycerol or other cryoprecipitants to your stool slurry and prepare in advance, keep it frozen and thaw it in the day, there's been a shift towards a more high throughput, safe means of doing things. So instead of using related donors, we tend to use healthy, unrelated screen donors, so we can screen in advance. There's been this trend towards bookending screening, in other words, whereby we do a full set of screening at the start of a donation period, allow a donor to donate for a fixed period of time, make FMT from all the stool they donate, but keep in quarantine for that period, and then repeat the screening at the end of that period. And only when the screening is still negative at the end of that period do we release the FMT for use. And this has allowed the establishment of stool banks and hub and spoke services. In other words, whereby there's a stool bank that's a central FMT store and spoke services that are dependent on it. And the model for stool banks has been Microbiome, which is a service that's been in the United States, in Boston, which has been a huge stool bank recruiting MIT students, and has been a sort of model for how stool banks have helped to establish themselves throughout the world. Conventionally, when people were talking about administration, there were just 2 things you talked about: upper GI versus lower GI administration. And the clinical evidence, this is some recent work we were involved in, slightly favors lower GI, colonoscopic administration. However, with all administration, there's a balance between what may be efficacious and what may be a slight increase in efficacy versus what's feasible with a patient in front of you. And our cohort with patients with recurrent C. difficile infection are typically older, frail, and may not be able to tolerate a colonoscopy. So we have tended to use nasogastric tube administration, and it's been highly successful and reasonably well tolerated. More recently, the new kid on the block has been capsulized administration, whereby capsulized slurry or lyophilized FMT has been used. And randomized controlled trials have established colonoscopic FMT versus capsulized FMT in patients with recurrent C. difficile from the same stool donation, and they appear to be of equal efficacy. So this seems to be a step towards modernizing practice. Regulation has been a thorny issue. In this country, in the UK, MHRA is deemed an unlicensed medicinal product, and the regulation is on the MHRA. Here's what we put in the national guidelines a few years ago. And we recommended clear traceability and guidelines that are commensurate with you find with a medicinal product. Internationally, there's been an ongoing debate about whether stool should be treated more as a tissue or more as a drug. Something else that's been done internationally, but we haven't been so good at the UK, is the establishment of FMT registries to allow early, looking at efficacy, to allow some research themes, and to hopefully allow early identification should there be a problem with a batch whereby, say, there was a novel infection that appeared. And in fact, the USA have reported their AGA-sponsored registry results in a recent paper in gastroenterology. In terms of mechanisms, this was an interesting paper from 2017 in Gastro, whereby 5 patients with recurrent C. difficile were treated with sterile filtered FMT. In other words, the FMT was made as normal, but filtered through pores that were smaller than the diameter of a bacterial cell, and were given to patients with similar efficacy to conventional FMT. In other words, it suggests you don't need live bacteria in there, but you might just need microbial products. But what else could it be? It could be gut microbial metabolites. It could be the multiple viruses called phages, or the fungi, the so-called microbiome that's in there. There could be competition between the restored bacteria or their products for C. difficile with energy sources, or it could be antibacterial proteins, bacteriocins, or it could be some direct soluble mediator that impacts upon the immune response. And some of those factors are sort of summarized here in our in a paper where we looked at this recently. So lots of our research has kind of drilled down on the gut microbial metabolite side. We've got a sort of long-standing interest at imperial metabolomics. And we found that FMT retreats recurrent C. diff, not only restoring gut microbiome composition, but also its metabolic functionality. In particular, we found that it restores short-chain fatty acids. These are microbial fermentation products from undigested carbohydrate amino acids. There's a restoration of microbially mediated changes in bile acids and other small molecules as well. And what's the impact of these metabolites? These metabolites seem to impact directly upon the ability of C. difficile to undergo germination or growth. They seem to outcompete C. difficile for nutrient sources in the gut, and they may impact upon the gut barrier. In the case of bile acids, we've also found that the restored bile acids are associated with an upregulation of FXR stimulation, which is associated with immune responses and feedback loops to other metabolites. So there seems to be complex whole organ effects that are driven by gut microbial metabolites. What's the impact upon the immune system? Here's some work we recently published looking at the restored gut microbiota, restoring the IgA profiles in the guts. There seems to be some direct link to the immune system. And FMT also seems to restore T cell library, seems to increase the immunological complexity of the immune system. So, this sort of gives some further insight into microbiome immune interactions, which has obviously been a key area of research interest over the past few years. But not only is FMT now established for C. difficile, but of course we've now got this increasing recognition of the multiple different disease groups in which perturbation of the gut microbiota occurs, including metabolic diseases, other GI and liver diseases, immunological diseases, even neuropsychiatric diseases. And of course, there's then been interest in saying if these diseases are also characterized by a perturbation of the gut microbiota, just as FMT has been a success for them, could it also be a treatment approach for these other conditions? Just to give a few examples that I think might be interesting to this audience, FMT for UC, there have been 4 randomized controlled trials in addition to some case series, etc. 2 have used autologous FMT, in other words, the patients in the study giving their own FMT, getting their own stool back, or 2 have used colored scented water as a control. Very heterogeneous in terms of protocols, very heterogeneous in terms of prior drug treatments, defining remission and response, defining remission differently, but response fairly similarly. But as you can see here across the forest plot, the overall implication being that FMT is more effective than placebo in inducing remission. However, these are sort of comparable rates to are seen to other very well-established, cheap, easily available standard of care therapies. And no further studies have looked at maintenance of remission. So these studies are still awaited. One FMT randomized study for Crohn's, patients recruited during flare while being treated with corticosteroids, colonoscopic FMT at recruitment, and again, one further at 6 weeks. 8 patients, small study, 8 receiving FMT, 9 receiving placebo. And the primary endpoint was actually looking at microbial engraftment, but also clinical endpoints were followed for 24 weeks. And as you can see, it didn't reach any particular endpoints. The only FMT is right on the borderline for CRP and some scoring systems as well. But there are some signals overall that FMT appears to be more effective than placebo. Again, a small early study suggesting there's a signal, further work needed. Given there's a number of surgeons in the audience today, I thought this may be of interest to people. FMT has been really of great interest in metabolic syndrome, including patients with type 2 diabetes, the full metabolic syndrome, non-alcoholic fatty liver disease. In this study published in Gut last year, 22 patients with metabolic syndrome were given FMT either from a donor who'd undergone Roux-en-Y gastric bypass surgery or a unconnected random patient with metabolic syndrome. And what was seen was a significant reduction in insulin sensitivity 2 weeks after patients had received FMT from the person with metabolic syndrome, and a trend towards faster intestinal transit time after RYGB. In other words, things get slightly worse when receiving FMT for metabolic syndrome, some trends towards some positive signals after receiving FMT from someone with RYGB. So pretty thought-provoking that after RYGB, the microbiota and metabolome changes that occur may be transferable to give metabolic benefits. Just as FMT wipes out C. diff from the system, we've also been interested in whether FMT might be used to decolonize multi-drug resistant bacteria from the gut of people who have them in a hospital. And we've been particularly looking at this at people who get the most problems with multi-drug resistant bacteria. We've been looking at immunosuppressed patients, including those with renal transplants or those about to have hematopoietic stem cell transplants, those at most risk of those guts translocating from the bowel into the bloodstream and causing bacteremia. And when we gave FMT to 20 such patients, this is a collection of patients with hematological malignancies, undergoing stem cell transplants, and patients with renal transplants, we saw actually lower rates of decolonization than we expected, only about 40%, which is what might occur spontaneously. But what we did see is these unexpected clinical benefits: a reduction in bloodstream infections, both multi-drug resistant organism related and otherwise, reduced length of stay, reduced need for carbapenem therapy, and in the patients who'd had recurrent UTIs related to these organisms, a reduction in the number of UTIs. Perhaps more intriguingly, we looked at the survival and general outcomes of our hematopoietic stem cell transplant patients who've been colonized with multi-drug resistant organisms who'd had an FMT and actually had better survival as well. As you can see, this isn't just over the first few months, this is over a longer term. So it's not just sepsis alone that we're knocking out. It seems that the FMT is doing something more profound to these patients. Another area is the role of FMT in cancer, and particularly in cancer therapies. And one particular area of interest is immune checkpoint inhibitors. We've now recognized that patients who've had antibiotics in the month prior to starting immune checkpoint inhibitors have worse outcomes, worse response to treatment than those who haven't had antibiotics. These are 2 studies out in Science this year, whereby patients were recruited who were melanoma patients who'd lost response to immune checkpoint inhibitors, and they were given FMT from a patient who responded very well to immune checkpoint inhibitor. And a small but notable proportion of patients seemed to regain a response to the immune checkpoint inhibitor. This was also associated with changes in the immune infiltrates into their cancer. So pretty thought-provoking data as well. What are the future directions? Well, there's been a growth in interest in capsulized FMT, as we've said, and actually rather than just taking whole stool products, of whether this can actually move on to more refined next generation FMT products. And the leaders in this are microbiome therapeutic companies who've arisen out of the United States with some positive phase 2 and phase 3 data. Finch are one such company. They've reported positive phase 2 data of using a whole microbiome product to treat recurrent CDI. Series are a biotech company who use who is actually not a phage-based product, it's a spore-based product that they're using, and that's also met a primary endpoint. And actually, these are moving into later phase large trials, and these companies are very hopeful these will be licensed. However, there's still many unanswered questions. Just because such preparations work for C. diff, they may not be that these are useful for all conditions where we're interested in change to the gut microbiome. We need greater mechanistic understanding, and we may need more targeted next generation FMT products for different different conditions. And there's lots of practical issues in terms of the expense of these agents, the licensing, and their accessibility. So conclusions, there's huge growth from the microbiome FMT, which is the marrying up of explosion in interesting next generation sequencing and other omics technologies, together with the early success of FMT for C. diff. There's been continual refinements in all aspects of the FMT pathway. Some of that's beneficial, such as stool banks, which is obviously good in terms of regulation, patient safety, efficiency. Some of that's bad, such as COVID-19 and other rare but significant reports of transmission of infection. There's a great interest in the role for FMT or other microbiome manipulation techniques for non-C. difficile infections. And there's many positive signals for a variety of conditions, but more unknowns than knowns at the moment, where we can't really move at the moment between positive signals onto something as a more sustainable therapeutic. Thank you very much for your attention, and please feel free to get in contact if you get any questions or comments at all. Many thanks.